Pulmonary embolism. Embolism means moving clot. Pulmonary embolism means in the pulmonary or in the pulmonary circulation there is clot. Okay. So actually the definition of pulmonary embolism is the obstruction of pulmonary artery or one of its branches by a thrombus that originated somewhere in the venous system. So the pulmonary embolism means it is a blockage that occurs in the pulmonary arteries. And this embolism commonly occur from the deep vein thrombosis, especially from the legs. So the pulmonary embolism means obstruction of pulmonary artery or its branches by a moving clot, that is pulmonary embolism. We can see the causes of or etiology of pulmonary embolism. The etiology include virtuous triad. So in deep vein thrombosis, you may have studied regarding virtuous triad. Virtuous triad include venous stasis, hypercoagulability, venous endothelial damage. So this is the main or important reason for thrombus or clot formation. Okay, when the thrombus is dislodged and enter into the circulation, then it is known as emboli. So the main causes of thrombosis is the virtuous triad, that is venous stasis, hypercoagulability and venous endothelial damage or disease. So the main reason is thrombus formation, that is virtuous triad. Then embolism, that means moving clot. Then trauma, not only trauma, especially the bone fracture, okay, especially the lower leg fracture, that's the main reason for emboli formation. Then surgery, some of the surgeries, the surgery may leads to immobility, okay, so that may leads to a clot or emboli formation. Then hypercoagulability, I already explained in virtuous triad. Then heart failure. Then pregnancy. In pregnancy, there is lot of changes occurs in our body. So increased coagulability is one of the reason in pregnancy. Okay, we have studied regarding the amniotic embolism. The same like there will be chance for pulmonary embolism too. And the emboli may consist the amniotic fluid too. Then older than 50 years, the age more than 50 years is a risk for pulmonary embolism. Then atrial fibrillation, atrial flutter, here there will be a fibrillating heart, okay, so that may leads to the thrombus may dislodge and move from the site and enter into the circulation, that is it happens in atrial flutter or fibrillation. So the main etiology I already told that it is virtuous triad, venous stasis, hypercoagulability and venous endothelial damage, and the that leads to thrombus and emboli formation. And other factors like trauma, surgery, heart failure, pregnancy, older than 50 years, atrial fibrillation, flutter, all these are the risk for pulmonary embolism. And DM, COPD and CVA also a risk for pulmonary embolism. Regarding the pathophysiology of pulmonary embolism reduces oxygenation and cardiac output. The more extensive the embolus in zero or number, the greater and more rapid the physiologic deterioration. The pulmonary emboli obstruction and vasoconstriction leads to decreased lung blood flow. That leads to ventilation perfusion mismatch. That leads to arterial hypoxia. In other area, it increased the pulmonary artery pressure and right ventricular dilation. So the right ventricular dilation that leads to decrease right ventricular contraction, decrease cardiac output, oxygen demand and decrease cardiac contraction, and ultimately leads to cardiogenic shock. So, in pulmonary embolism pathophysiology, due to the etiological reasons, there will be increased alveolar dead space that leads to decreased lung blood flow, that leads to the ventilation perfusion mismatch or impaired gas exchange. Then in another area, it leads to pulmonary artery pressure increase and right ventricular dilatation. So that leads to decrease right ventricular contraction and decrease cardiac output and increase oxygen demand. So what happens, the workload of the heart will be increased, but there will be decreased cardiac contraction. So this decreased cardiac contraction ultimately leads to cardiogenic shock by decreasing cardiac output. So that is the pathophysiology. It's a very simple pathophysiology. Then regarding the symptoms of pulmonary embolism, the symptoms, actually what happens is we have studied that ultimately it leads to shock. So most of the time when we are knowing that the patient have pulmonary embolism, is the main feature is syncope. Okay, most of the time the person may suddenly get loss of consciousness. So syncope is the main feature for pulmonary embolism. Then there may be chance for wheezing, dull chest pain, then pain on calf muscles. That means DVT. Okay, if the patient have DVT, there will be DVT means deep vein thrombosis. So thrombus will be there. This thrombus will be dislodged or moved into the circulation. That leads to that may enter into the pulmonary circulation and ultimately leads to pulmonary embolism. So there may be features. If it occurs from the leg, that means the patient will have DVT. That's why it is pain on calf muscles. Okay, it's a symptom of DVT. Next one, cough, because when there is the obstruction occurs, there will be inflammatory reactions and the patient may show the features of cough. Then hemoptysis. Hemoptysis means blood in the sputum. Then dyspnea, shortness of breath will be occur, and along with that there will be tachycardia, tachypnea, diaphoresis, increased perspiration. Diaphoresis means increased perspiration that may occurs. Then sometimes the person may goes to hypotension. Okay, especially increase cardiac workload and decrease cardiac output. So that's why there is a features of shock. There will be cold, clammy skin, syncope will be present, hypotension will be present. Okay, so these all are the symptoms of pulmonary embolism. So syncope is a main feature of pulmonary embolism. Along with there will be features of deep vein thrombosis. Then cough will be the, hemoptysis will be the, tachycardia will be the, tachypnea will be the, then shortness of breath, wheezing, dull chest pain. All these features may present with the patient, and sometimes the person may have fever too. The diagnostic tests of pulmonary embolism include imaging studies, especially chest X-ray, ventilation perfusion scan, spiral chest CT, then pulmonary angiography, echocardiography. It's the imaging studies that will helpful for the diagnosing pulmonary embolism. Then laboratory analysis like CBC, ESR, D-dimer. The D-dimer will be elevated in case of pulmonary embolism, as also in DVT. Then ABG analysis. Then ancillary testing include the ECG and pulse oximetry. The person will have the hypoxemia and the ECG variations. So sometimes the atrial flutter, atrial fibrillation, all this may cause pulmonary embolism. So the ECG variation will be present because there will be features of respiratory failure, cardiac failure, shock, cardiogenic shock. All this may present. So the ECG changes may occur in not may occur, it must be occur in pulmonary embolism. And while taking chest x-ray for diagnosing pulmonary embolism, there are some signs in the chest x-ray will helpful for the diagnosing pulmonary embolism. The first one, Fleischner sign, Hampton sign, Westermarck sign, knuckle sign, Palla sign, Kang sign, pleural effusion. All these signs may occur along with the pulmonary embolism. Most of them together will not be there, but all these signs as an indicator of pulmonary embolism. Okay. The Fleischner sign means enlarged pulmonary artery due to thrombus formation or the emboli formation. There will be enlarged pulmonary artery. That is known as the Fleischner sign. When we are observing X-ray, you can see the enlarged pulmonary artery. That is known as the Fleischner sign. Next one, Hampton hump. Hampton hump means peripheral purge of airspace opacity and implies lung infection. So here when we are observing the peripheral area, peripheral purge of airspace, there will be opacity. Opacity will be seen. So that means there will be lung infection. So here there will be decreased blood supply or there is no blood supply to the area. That's why the blood flow is cut off to that area. That is known as the Hampton hump. So in that area there will be airspace opacity. Then Westermarck sign means regional oligemia and highest positive predictive value. So you just understand regional oligemia. Here there will be a particular region there will be decreased blood flow. That is known as the Westermarck sign, decreased blood flow to a particular area. Then pleural effusion means effusion or fluid collection in the pleural space. Then knuckle sign or the Palla sign means enlarged right descending pulmonary artery. So in Palla signs there will be enlarged right descending pulmonary artery. Then Chang sign means dilated right descending pulmonary artery with a sudden cut-off. So Chang sign means dilated right descending pulmonary artery with a sudden cut-off. So these signs may ask in your PSC exams. All these signs in which condition you are seeing. Okay, like that they may ask questions. So you just understand which the signs only. Okay. The law explanation is not needed. Just understand these are the signs that may associated with pulmonary embolism. So once again, these all are the Fleischner sign, Hampton hump, Westermarck sign, knuckle sign or the Palla sign, Chang sign and pleural effusion. These all are the signs of pulmonary embolism. The medical management of pulmonary embolism include non-pharmacological management and pharmacological management. So in non-pharmacological management, the oxygen therapy is very important. Then anti-embolism stockings or intermittent pneumatic lung compression devices in order to prevent DVT after surgery. Then elevate leg above the level of the heart. That will helps to improve the blood flow and prevent venous stasis. So these all are the medical management. So anti-embolism stocking, then intermittent pneumatic leg compression devices, then elevation of leg, oxygen therapy. All this will helpful to prevent the pulmonary embolism. Next one, drug therapy of pulmonary embolism. The main drug therapy is anticoagulant therapy, started with heparin. Immediate management or immediate prevention is IV heparin, and the therapy will be adjusted with the partial thromboplastin time. So when we are starting coagulation studies, we have to assess for the coagulation profile. Okay, then long term prevention, we are giving warfarin, that is oral anticoagulant. Heparin is an IV or subcutaneously we can give one, and warfarin is oral anticoagulant. Then next thing what we are using is thrombolytic therapy. In thrombolytic therapy, the main thing is a tissue plasminogen activator. Then urokinase, streptokinase also can be given. So tissue plasminogen dissolves the pulmonary emboli, and the source of thrombus can be removed by the thrombolytic therapy. And this thrombolytic therapy or the anticoagulation therapy should be contraindicated in case of blood dyscrasiosis or the hepatic dysfunction, overt bleeding, or history of hemorrhagic stroke. All this condition, the thrombolytic therapy or the anticoagulant therapy is contraindicated. So the main management when we are asking for pulmonary embolism is anticoagulation therapy and the thrombolytic therapy. Surgical management include pulmonary embolectomy, requires thoracotomy with a cardiopulmonary bypass technique. Then transverse catheter embolectomy is a technique in which a vacuum coupled catheter is introduced transvenously into the affected pulmonary artery. Then suction is applied at the end of the embolus, and the embolus is aspirated through this cup. So the surgical management mainly the embolectomy, pulmonary embolectomy, and it can be done by transvenous route also. Okay, so that is the surgical management. So the main complications are palpitation, heart failure or shock, respiratory distress, hemorrhage, then pulmonary hypertension with a recurrent pulmonary embolism. So the main complication is sudden death, then a shock also associated with that. Then along with that, there may be chance for respiratory failure, pulmonary hypertension, and pulmonary infarction. Okay, these all are the complications associated with pulmonary embolism. I hope you understood regarding the condition. Thank you.